picture of the old endoscope that we had in 1995, and you see the poor quality of the picture and the bad illumination. We used the halogen light source and one chip camera and a small monitor, and this is the quality of picture that we had before. And this is the floor. This is the third ventricle, the choroid plexus, and the septum pellucidum fenestrated in chronic hydrocephalus. And here is the floor with the mammillary bodies. I just put it to see the quality, the bad quality that we had before. The second main indication of endoscopy is the colloid cyst. Here's the colloid cyst obstructing the foramen of Monroe, as you can see here, and the choroid plexus through the right frontal approach, elevating the floor of the lateral ventricle and elevating the fornix, disturbing the anatomy. We have to hit the wall of this colloid cyst and taking this material out. Here's the after coagulation and opening the colloid cyst. We are sucking the material of the colloid material from the inside the cyst. Here is the fornix, here is the wall, and here is the choroid plexus, the thalamostriate vein, and the septal, sorry, the thalamostriate vein and the septal vein. Actually, I'm using raw videos just to put you in the situation of these surgeries. Here's the colloid material. Here's the colloid material, sucking with a suction tube. The choroid plexus starting to collapse and dilatation of the foramen of Monroe. Continuing irrigation and suction takes around 1.5 hours, according to the size of the colloid cyst itself.
The portal of entry is this one.
The portal of entry is Kocher. Kocher. Is Kocher right frontal Kocher. Straightforward. We dilate a little bit the borehole. Is dilated a little bit laterally. It's not 10 millimeter per hole, maybe it's 12 or 13 millimeter per hole, and dilated laterally off the mid-pupillary line, just to hit the septum pellucidum in the midline. Is after evacuation of this colloid cyst and trying to grasp the wall, trial to grasp the wall, take a biopsy, and it may come out. Sometimes it comes out and sometimes not. There is some traction of the wall. I don't recommend to do this anytime you have hitting this type of pathologies. May bring a venous bleeding from an important source. We're trying to come with the colloid material, with the colloid cyst wall out. Actually, in this patient, we didn't succeed in that, and just coagulate and leave it as it is. 5 years follow-up, no recurrence. Thank you.
Okay, thank you, Dr. Darrag. Any questions or comments? Mr. Ali?
criteria of selection, first of all, the aqueduct stenosis or obstructive hydrocephalus. You have a dilated lateral ventricle and third ventricle. The third ventricle and the foramen of Monroe must ease the introduction of the endoscope with the diameter that you're using. The diameter we're using is the gap endoscope, and the diameter is 6.5 millimeter. So you have to ease your way in lateral ventricle, the foramen of Monroe, and the third ventricle. The third ventricle, the diameter must be not less than 1 centimeter, and the prepontine cistern must be not less than 2 millimeter to accept the introduction of your probes.
Size of the head, is it not a case of the face or
The size?
size of the head is very huge.
So the hydrocephalus here, or the hydrancephaly. The hydrancephaly, I don't think there is a place for endoscopy in hydrancephaly. You have to put a shunt, maybe 2 shunts even, in hydrancephaly. The endoscope will not work in this type of patients, because there is another pathologies in these patients. There is poor absorption of CSF in these patients.
And regarding
Like, in dealing with the craniopharyngioma,
Yeah.
are you going only to do opening, or what about the sulfur?
No, this is a cystic third ventricular craniopharyngioma, and this is an endoscopic ventricular approach to third, which is a very rare type of craniopharyngioma, isolated third ventricular cystic craniopharyngioma. This is not the common craniopharyngiomas that we're seeing.
the place of the fornix, because you are very near to the fornix.
Yeah.
Is there any chance to be injured or to be?
Yeah. Actually, there is no problem if you sacrificed one fornix on one side, there will be no problem. Many studies upon that, and my personal experience is no problem that you injure the fornix on one side. But actually, there is points. It's better to injure the fornix at them, which is near the choroid plexus. Near, I mean at 3 o'clock from the avenue of your endoscope at 3 o'clock. The choroid plexus usually at 6 o'clock, and your introduction or the injury of the fornix at 3 o'clock. You always not to injure the fornix. You have to calculate first the opening, which is the diameter of the foramen of Monroe. This is most important. Second, you have to put everything important not in view. You don't have the fornix inside of you. Just put it behind, and you will not injure it. But do not manipulate a lot. You go straight forward.
And what about the efficient approach and the closer approach?
Endoscopic.
Yeah.
I don't have this kind of experience.
Interhemispheric.
Interhemispheric, microscopic, but not endoscopic. Microscopic interhemispheric, transcallosal. This is microscopic, not endoscopic.
Endoscopic can be done.
Yes, I know it can be done, but I don't have the experience in that. Yeah. No, I don't. It's difficult extraterritorial.
By still meeting the criteria for precision based on the selection, is there any present chance to save the for already operated hydrocephalus
Yes.
by vision?
Yes. There is no problem in that. You can operate in patients with obstructive hydrocephalus and non-working or non-functioning shunts and they come to you and you do this procedure, just go for third ventriculostomy and there is no problem and it's not affecting the outcome of your patients.
I'm just asking about the cost of surgery by endoscopy. Is the same as
The cost?
yes.
This is a good question. The cost of surgery, the cost effectiveness of the endoscope, I think it matters a lot in our countries, Egypt or Sudan. But I think it's much cheaper for the patient to go for the third ventriculostomy. You purchase the instruments and things like this and this upon the hospital. But if you calculate, if you have one patient with one surgery, this is better than you have one patient with 10 surgeries, with obstructive shunts and and the infection, the external drains, and you put it like that. So it's much cheaper if you calculate it that way. It's much cheaper than a VP shunt.
Are there any chance to get some sort of stomach obstruction or stenosis?
Yes, yes. Recorded stenosis of the stoma, and it's late, and as we just said that it's very late and it's very low percentage, just 2% that you have a restenosis, and it's very low incidence.
Can we put a stent or something?
I don't think that this percentage needs a stent. It needs a redo, and that's it. A redo after 2%, to redo after 6 or 7 years. It's okay. Yes. This is a very good question, too. First of all, we are talking about straightforward third ventriculostomy. Everything is okay. The lateral ventricle is okay. Dilated foramen of Monroe, and everything is fine. So the last part is opening the floor. While opening this floor, you have criteria in the floor. If you have a thick floor, this will add to the failure rate. So if you have a thick floor, multiple septated arachnoids inside the prepontine cistern, this will add to the failure. Non-pulsating, oscillating floor, this will add to the failure. And difficulty to puncture the floor. You cannot puncture the floor, so you have a definite failure. To a shunt, definitely, yes. And you have to tell your patient every endoscopic procedure, you have to tell your patient that you may go to put a shunt in the same procedure.
Back to the criteria of selection of the patients. If there is any preferable aid for intervening endoscopically for the obstructive hydrocephalus?
Yes. Many studies in that, before 6 months of age, after 6 months, before 1 year, and after 1 year, and things like this. Actually, I think the range difference between these children at 1 month of age and these at 1 year of age is ranging from 50% to 75%. So there is a chance for these children with at 1 month age to have